There we go. We should be recording. I'm going to go ahead and back up this lecture by recording on my phone as well, so that we have an audio should the video fail. Hello, students. We're going to talk about the 12 core functions of a professional helper. It is I, Dr. Conley, and Christy Aristy. And
hi, everybody.
We'll be talking about this in a sort of an informal way. Christy and I are going to talk back and forth. We'll go through the screening, intake, orientation, assessment, et cetera, and cover these. I'm looking at through my sheets on the left, and we're going to walk through these PowerPoints that cover this material as well. As I was saying to Christy before we started recording, if I have any recording or audio visual problems, I'll try to fix them on the run. If for any reason the video fails, I am audio recording on the left. In fact, Christy, could you say something again? I want to be sure my phone is picking this up on the record function.
Hi, everybody. I'm Christy Aristy.
Great. Christy, that worked out well. I can see that my phone is picking it up. So we do have a backup. Love to always have a plan B in case anything goes wrong. So let's go ahead and start talking about these 12 core functions of professional helpers. We have screening to begin with, the process by which the client is determined appropriate and eligible for admission to a particular program. Some global criteria of screening, Christy, are?
Evaluate psychological, social, and physiological signs and symptoms of alcohol and other drug use. Determine the client's appropriateness for admission. Determine the client's eligibility. Identify coexisting conditions, including the behavioral health model of medical, psychiatric, physical, etc. Adhere to all laws, regulations, and agency policies for any kind of substance use services.
So as we're screening, we're trying to determine if the person, do they belong in this program? Are they in the right place? So in order to do that, we're going to be asking them questions or administering them some brief instruments, you think?
Yes, absolutely. Through the screening process, in New York, what we do is we look to see if the person, first of all, has the insurance to come into a program. If the person does have the insurance to come to a program, what we're looking for is to see if the client is eligible to receive their services in a particular organization or a program. This includes, does the person meet the eligibility criteria for insurance? Do they meet the eligibility criteria for income? Do they meet the eligibility criteria for race and ethnicity, right? Because there are some programs that are very specific to that. Do they meet agenda criteria? So we always screen out clients to make sure that they're appropriate for any type of programming available in any substance use program.
Okay, so we're working in an OASIS, publicly funded addiction services clinic. Somebody comes in and we want to be sure they're in the right place. And if they're not, we don't just go, sorry, you're in the wrong place. I mean, then we have to slip into one of the other domains we're going to cover here, like case management, referral, et cetera, et cetera. But the screening is just to be sure that they are appropriate for where they are.
Right.
Different clinics have different criteria that clients must meet in order to get the service. One of those that you mentioned, Christy, was insurance. So do we have to pre-certify their insurance right here in the screening part of the intake?
Yes. What happens is that if a program doesn't have what we call deficit funding, which is where they're getting state or federal benefits to help people who don't have insurance, they have to go through the patient's insurance and they have to see if the patient has the right health managed care, or if they have a particular federal fund like Medicaid or Medicare.
Sure. And as we move through the list of core functions, we'll see there are others that will come into play. So these aren't necessarily discrete phases. If somebody is not eligible, as I said, we do have to start case managing them and refer them to where they are. It may be that they haven't assigned for or applied for insurance yet, and then we need to see that they're able to do that and make sure that they get to the right place that they need to be. The other thing is this clinical screening. We need to determine, does this person actually have an alcohol or drug abuse problem? Are they likely to? I mean, we're not going into diagnostic procedures here, but are they likely to have an alcohol and drug abuse problem? We want to know if there are certain brief screening instruments you can use that will put them in the 95% likely that they have the diagnosis when we get there. So we want to be sure if they have the physiological signs and symptoms, likely to meet, say, a DSM-4. I put in per DSM-4, I meant 5.
Uh-huh.
I'm on a DSM-5 now. Been almost 5 years, and determine, their appropriateness. So really, we just want to screen for this. So I'm going to go ahead and move along. Anything else about screening before I slip slides here, Christy?
Nope.
Good.
Mm-mm.
Then, so we're going to advance these. Now we're going to do the intake. We're going to go ahead and engage in the administrative and initial assessment procedures. Generally, an extension of the screening process. We decide we're going to admit the client. We're going to, formally admit them and go ahead and document that. Can you talk about intake just a little bit, please, Christy?
Sure. This is the most imperative part of any person's treatment history. The reason why is because of the global criteria number 8. It's the obtaining signed consent. In this particular stage of intake, we really make sure that the client has to be protected and that they're willing to sign these consents in order for us to speak to either collateral sessions, meaning they're talking to significant others. If they have a primary care provider, that we're speaking to the primary care provider, both releasing and exchanging information. I want to be very specific about that. Because the idea is that when you obtain consent, you're releasing and exchanging information so that those providers, the significant others, whoever the client is working with, they always remain part of their treatment process.
Sure. Just a word on that terminology too. There's a whole reading on just the terminology of addiction, and collateral context comes up. That is just the language of the land when you're working in the field of substance abuse. Did you get to your collateral context, or sometimes just, what did you hear from collaterals? It's just the language. And collaterals means the other providers, this is the family members, sometimes the employers, the person who referred them to you in the first place, the social worker who referred them to you in the first place, the
parole officer, probation,
shelter, public welfare, all of those are collateral contexts. And for every single one of them, we have to, at intake, have a consent form signed so that we can release and exchange what really is confidential information. We'll do more on confidentiality in subsequent modules, but yes, we have to have the consent signed. The other, confidentiality I see is bolded on the slides.
That's right.
The other thing we're determining here too, we want to be sure, is the level of care that they're coming into appropriate. If we are I don't know, give me a level, Christy, a level of treatment, intensive outpatient.
So in New York, there are many levels of treatment.
There are many levels of treatment. Again,
many. There are about 17 levels of treatment.
So,
I wish I was
let's
kidding.
keep it simple. Let's keep it simple.
So we're going to keep it simple for this one. But basically what you do is to see if the person is eligible. Sometimes clients have what we call restrictions on their insurance. Now, the restrictions mean that the client is only eligible to receive a particular type of service. For example, if the client is restricted to a hospital, that means that they may have to receive detoxification services, rehabilitation services, and possibly outpatient services at the same hospital. Restrictions mean that they cannot go to any other providers except that provider.
That's perfect, because it prevents a fragmentation of services. We want an integration. We don't want people getting one service over here. Like, I get my meds from these people. I get my mental health from these people. I get my substance use from here. We want that integrated model of care so that it's really everybody is in the same place. So at intake, we're determining, are they eligible completely? Are they eligible? Are they appropriate? And we want to be sure that they're receiving the level of care that is best matched to to what it is that they need. And often that will be determined before they come to a particular setting. For example, if you're in a residential, an inpatient level of setting or a detox level of setting, that will have been determined before they get there. But we always want to confirm that and complete all the appropriate documentation. There is a lot of documentation, not just in substance
Sure
use
is.
counseling, but in social work. You've got to be quick. It's part of the reason we push throughout the social work curriculum, writing, always writing. You've got to be very quick with one of these and very quick with these and all of these on computer screens. So, we need to be able to get that information in there as quickly as possible. Client has gone through screening. They've had their intake. They will be oriented. So can we talk about orientation a little bit, Christy?
Sure. Orientation happens at the very beginning of treatment and then throughout treatment. So what happens is that sometimes at the very beginning of treatment, clients need to understand the rules and regulations of the programs that they're volunteering to come into. This includes the hours of operation. This includes the hierarchical structure, what each person's role is, having access to the grievance procedure, things like this.
Sure. And if we
also
go back,
have to know who the program supervisor is. Mm-hmm.
Well, in intake, not to cut you off, they may actually sign documents saying, I agree to participate in the program, and you'll have what's called a client participation agreement. I'm coming into the program, blah, blah, blah. I'm signing this. That means that I will undergo a psychiatric eval. I will have my medications reviewed. I will be screened for public health reasons, right? Didn't you mention in a conversation the other day, public health requirements, some programs, if you're coming to the program, you will get a TB test. You want to be sure that the client is getting all of that, understanding it and getting it signed off on, correct?
Absolutely, because there are what we call block requirements, but we're going to talk about that a little later on.
Okay, sure. And programs have, as part of the orientation, it's like, okay, let's be sure that you know that you're getting into, what you are getting into. We want clients to be informed consumers of the services. We don't want them to come in and like, I didn't know we were going to do this, or we don't want them 4 sessions later to say, I didn't want to do this. It's, it's like, okay, let's orient you. Here's where you are. Here's what you're doing. Yeah. So, other stuff on orientation, I guess that's going to vary by program, level of care, setting, that kind of thing, Christy.
Yeah, but sometimes what happens is that people often ask me, why does orientation? Because orientation sounds like that happens at the very beginning. So why do we consistently, complete orientation over the person's treatment course, right? The reason why is because when a person is first coming to you and they're in pain or they're in withdrawal, or they're under the influence, or they're just kind of yesing you to death because they know that they need the services, they don't pay attention at the very beginning. So what happens is that they're like, yeah, I heard you, I'm going to sign. But then you have to say, hey, let's talk about the program rules over a period of time, right? You signed on for it. Do you still agree to this? Are you still volunteering for this? Okay, well, let's move on to the next thing you agreed to do. So orientation happens over the course of treatment because you don't know what state the patient's coming in to meet with you.
Sure. And, by nature, if somebody's in an acute phase of addiction, intoxication, just recently detoxed, they have a co-occurring mental issue of, they're depressed or manic or, just they have some mental status issues. Yes, you want to continue to orient them to say, hey, this is what we're doing, remind them this is what we've been doing. This is where this program goes next. So that's great. Important to know that. Let's see, keep going with, looks like assessment is coming up. My favorite, Conley.
This is mine too.
This is mine too. And let me tell, I'm speaking directly to the students. Why do the professors get excited about assessment? Because boy, if you don't come out of the assessment with the proper diagnosis, you're treating the wrong thing. That's
absolutely.
And it's horrible. And unfortunately, it happens and everyone's often students, Christy, as we know, are concerned with misdiagnosing. You should be concerned with misdiagnosing. I mean, it's not the end of the world, but it's so important that you identify, not just the psychopathology and the specific nature of the addictive, disorder, the criteria they're meeting, but, what are their strengths? What are their needs for, opportunities for construction of a treatment plan? Assessment is ongoing. And, with a good assessment, you will be able to formulate a good treatment plan and likely have a better outcome. So your thoughts on assessment as well, Christy?
Yeah, this is the greatest part of being like having social work and addiction work together, because you really get to see the human, behavior in the social environment, right? You get to see where the person is. And you also get to see where the person's first point of trauma is and if they've grown from that point of trauma. Like, for example, if a person had their first trauma at the age of 8 and the person is sitting in front of you and they're 30 years old, your assessment may very well tell you that although this 30-year-old is sitting in front of you, the person has a mental state of an 8-year-old. So that's kind of how you operate with them going forward. So assessments really tell you how to work with your client to get the best outcomes for them.
And we know that, here comes the red pen. I'm serious. We know that as social work students that you are getting, speaking directly to the students now, that you are getting additional coursework specifically on assessment evaluation, how to engage, how to have the conversation with the client, how to ask those diagnostic questions. We know that you're getting that in other courses as well. In the field of addiction, in addition to all of the foundational level clinical skills that you're acquiring in your other courses, in addiction, we steered in a particular direction. So we want the relevant history. And one of the bullet points on our slide here, identify and utilize appropriate assessment tools. There's a whole separate set of assessment tools that go along with determining the presence or absence of diagnostic criteria, the presence or absence of a substance use disorder, what kind of substance use disorder there is. So, and this is kind of a module 1, getting into the overall picture here, but there will be a core function is assessment, and within that assessment, there are many more specific evaluation instruments that we'll be getting introduced to here shortly. All for the purpose of developing a diagnostic evaluation to facilitate the treatment planning. So obviously we're excited about the assessment part, that it's done right, that we'll be giving a good deal of information on that because we want to develop a diagnostic evaluation and any coexisting conditions based on the results of all assessments. Christy, do you want to give a little word on coexisting or co-occurring and where that comes in this assessment piece?
Absolutely. So basically what we do in either a private or public setting is we look to see if it's a co-occurring disorder or if it's not a co-occurring disorder. Now, if it's not a co-occurring disorder, for example, a person has a medical condition that is creating some form of psychosis in the individual. That's the medical condition that's causing the issue. We know that that's not a co-occurring disorder. We just know that it's a medical disorder that's causing a person to have a psychotic issue. Now, a co-occurring disorder would be addiction, mental health, or a medical condition that happen kind of simultaneously, but are not the cause of one another. Okay, so that's a co-occurring disorder. Two disorders that are happening at the same time. What happens in the assessment piece is if a person is suffering from a co-occurring disorder, what happens is that we know to treat both disorders at the same time to get the best outcome.
Yes.
And the reason why is
to not fragment that service, to not say, oh, that's a mental health issue, we're not dealing with it. Oh, right. And they have the mental health person say, oh, that's a substance issue, we're not dealing with it. It has to be an integrated treatment plan. Go ahead, please.
No, that's basically what we do. You are absolutely on target with that. The other thing that we do too is that we make sure that the person has the most supportive services. Because here's the deal. If the person has two disorders that are happening at the same time and the person sees that one of the disorders have these wonderful, measurable, achievable outcomes, they're more likely to work on the second disorder. Okay, because a lot of our clients like to see some kind of positive outcome in order for them to continue to work on both things at the same time.
Mm-hmm, mm-hmm. And it gives me a chance to raise an enduring harmful myth in the field of mental health practice, which is if somebody has, say, a persistent depressive disorder and an alcohol use disorder, it's often the default of a mental health practitioner to say, well, if we get the depression to go away, they'll stop drinking because they're drinking
Yeah.
to try to treat their depression. So let's cure the mental health problem, and the substance
Hmm.
use issue will, I don't know what, just go away all by
Yeah.
itself. So there's been
No.
a long-standing misunderstanding that,
Mhm.
that would be the mode of practice. We'll take care of the bipolar disorder, the alcoholism will go away. We'll take care of the anxiety and the use of benzos will go away, but it's not. Co-occurring means they're occurring at the same time. And in assessment, from screening through to assessment, we want to say, is there evidence of a mental health problem here? Now, it may be that when the substance use goes into remission, so does the co-occurring mental health problem. It may be, it may not be. It may be that the substance use goes into remission and you still have a person who's persistently depressive or overly
Absolutely.
anxious or bipolar mood disorder. Maybe, but we're trying to tease these things out in assessment and be aware of them as we move from assessment into treatment planning. Last thoughts on this slide, Christy?
Nope, that's it.
Great. Treatment planning. Well,
Yay!
pretty straightforward. Let's get them into treatment. We've done our screening, assessment, evaluation, diagnosis. Let's get them into treatment planning. What do you think?
Well, here's what's great about treatment planning. It's always mutual. It's always a mutual collaborative experience where the
Especially for
client.
social workers. Yes.
Mhm. So the client tells us basically, look, this is what I want to work on. And you get to say, okay, what are the steps? What are the objectives we're going to take to get there? And this is the type of intervention that we're going to use. If this intervention doesn't work, we're going to try another one. That's what's great about treatment planning. It's the client deciding and the client remaining an expert in their own lives.
Treatment plans sometimes are standardized and determined, guys, by the setting that you're in. There'll be a treatment planning documentation or a treatment plan. You may be using an electronic medical record system which has certain elements prescribed, so that if they meet these diagnostic criteria, they're going to get these treatment elements, or say they're going to, these are the treatment elements that are going to be suggested. I love Christy's empowerment idea that this is a collaborative process with the client. It's not us as the experts coming on from on high saying, okay, thank you, we've determined that you have this and you're going to have to do that. It doesn't work as well I don't know, maybe it works well with something, but it doesn't work well with treating substance use disordered
No.
clients. We need to say, here's what we've determined is going on based on this is collaborative. You're telling me that you're part of the assessment, the information you've given me, we're organizing it out this way. Here are some things that we can do to treat that. Let's put this together with you, and we're going to come up with a treatment plan. And the treatment plan, sometimes you're even going to say to the client, do you agree to this treatment plan? Good. Could you sign here that you agree to this treatment plan?
Absolutely.
If you're dealing with, I don't know, personality disorders, oh God, I can't wait to get to that. But if you're dealing with some characterological issues, or someone who's, generally making and breaking rules a lot, depending on their lifestyle, you'd like to have them say, well, you may need to come back later and say, this is the treatment plan we've agreed to. Are you engaging in the treatment plan or not? If not, why not? That kind of thing. So we really want to kind of codify that, Christy, right? Does that sound right based on your extensive knowledge of agency-based practice, right?
Well, yeah, treatment plans are definitely a prescription. That is the correct term to use, according, for a person that's Medicaid or Medicare. They actually look at the treatment plan as a prescription pad for social workers and addiction counselors. It is that, you and the client are agreeing that this is what we're going to prescribe going forward in your treatment over a duration, right? So is it 30 days, 90 days, 120 days? And did it, and if it didn't meet the criteria or if it didn't work, did you modify it again during that period so that that patient has the best outcome?
Yep. Modification of treatment plans, treatment plan update, treatment review. The plan is, this is, what we're doing. And you will staff clients, and I'll sit and say, we're updating treatment. Where are we going to go with this guy? Where are we going to go with that guy? I'm thinking of the residential level of care, do we need to change the treatment plan, based on what we've learned is going to be going on with them medically, et cetera, because things develop. Someone comes in, they settle down, it's like they get their first medical screening in years, and it's like, well, we were
That's
planning
right.
on doing this, but guess what? Now we have all of this medical stuff coming up that we're going to have to deal with. We didn't realize that they have this severe vision issue. So the treatment planning, I guess it's ongoing, right, Christy? Ongoing, subject
Absolutely.
to changing over time. Okay. Goals, objective-based, et cetera.
Right.
Counseling. Well, they call it addiction counseling. So
Yay!
that's the utilization of special skills. We have as social workers specializing or practicing in the field of addiction, there are special skills to assist individuals, families, couples, or groups in achieving their objectives by exploring stuff. So much about counseling. We have to determine what model we're going to use. So where do we want to go with this part of the lecture, Christy?
This is where theory meets practice, Dr. C.
What's
This
that?
is the best part.
It is.
This is
So
where,
how's it best? What do you got for us?
well, here's the deal. This is where you actually get to practice your skills. So let's say you like the idea of using cognitive behavioral therapy. You actually get to practice cognitive behavioral therapy and its methods and use its tools during counseling. Let's say you're interested in something like motivational interviewing, patient engagement, and patient empowerment. This is where you get to use your skill sets to work with the patients.
Sure. The counseling is the engagement part, hence the little picture on the slide of, sitting down and talking with somebody. Let's go through this work. Let's go through this workbook, it's the talking part. There's definitely a role for talk therapy, and the different models that you mentioned. Cognitive behavioral therapy is an evidence-based practice model for working directly with people who have substance use disorders. So this is where the EBPs come into play, in fact, are required. And just a note, in evidence-based practice, you'll hear about it in your other courses, I'm sure, as time goes on. Basically, it is a practice for which, a model of practice for which there has been empirical or research-based evidence that the outcome is better than doing something else. So with cognitive behavioral therapy, it's been studied that if you, in controlled trial studies, you have this group of people get cognitive behavioral therapy, this kind of people get some other therapy, they compare them, and it's like, CBT works best. One evidence-based practice for substance abuse counseling is 12-step facilitation therapy. It's a model we're going to be exposed to a little bit later on. So we'll be exposing you to these models as the course goes on, but basically those are counseling models. It's what you're presenting to the client, it's how you're interacting with them to try to reach the goals and objectives set on the treatment plan, all of which flow from the assessment evaluation from screening forward. So in the counseling, it's most of the hours, right, Christy? It's most of what we do. It's really where we're trying to get to.
Yeah, we spend a lot of time in counseling. Mm-hmm.
That's why it's called addiction counseling. Okay. Part that we alluded to earlier is going to come right up. And again, all of these are, not discrete. It's not like we flow from 1 to 12, but case management comes to bear. So Christy, you want to start on case management? I've got a whole spiel I can go into, but go ahead.
Sure. So case management is where we bring people together to work with a particular client. That this is the primary care provider. This is the psychiatric services. This is the significant others. And these are resources that the client wants and wants to participate in. And also some things that we feel as addiction participants that we think that the client may need in the future. So it's basically a coordination of care of services and it's a collaboration of services to make sure that the services are good for the client. So it's a continuation of those services, like visiting the site, making sure that the client is receiving the right prescription medication, and things like that.
Yes. It can even come down to the nuts and bolts of setting up transportation from place to place and treatment event to retreatment event. Could be scheduling appointments with the client, sitting down. It's like, oh, okay, cool. Let's call the doctor right now and make sure that you
That's
get that
right.
appointment for next, Tuesday at. Now my phone goes here. I pick it up. Somebody tries to call me, right? Making sure that that an appointment is in place, that transportation is in place, that other services are, making referral for. Okay, yes. So the big stressor in your life is trying to get your mom into assisted living, or you're trying to have to deal with another family member. So it's like, yeah, okay, as part of your whole life thing. I mean, we need all of these domains. Work, right? Trying to maybe connect with job services, negotiate unemployment benefit. This is such social work. And I know, again, students, I know we're going to get this in other
Yeah.
classes as well, but case management and substance use can be fairly specific, yes. And even if it's qualifying for negotiating the systems to qualify for reimbursement of services. I started to play with my mouse here to try to circle collateral contacts because, again, it's a lot of phone time, can be a lot of email. Yeah. So let's jump out of that into crisis intervention. Services which respond to need during acute emotional or physical distress. Where do you want to go with this, Christy?
So crisis intervention is a little bit more difficult. With patients, what we do is we see that there's a crisis very much between the first month and the third month, right? This is when the client is having the most kinds of episodes of crisis. And then over time, the crisis turns into conflict, anywhere from 3 months to 6 months. And then from conflict, it turns into a daily living skill, anywhere from that 6 months to 12 months. So crisis intervention happens very often at the very beginning of the person's treatment because they have lost a lot of their adult living skills. They have an emotional depletion, so their capacity to deal with their emotions is not there. So, a train ride can be a crisis to them.
I like that. I'm going to interrupt and reiterate that. A diminished capacity to deal with. Could you say that again? Emotionally diminished. How did you put that? That was pretty good.
So they have emotional depletion.
Yes, they're emotionally depleted. They're exhausted. Everything is like, it is. And it can be up to us in the context of our counseling skill, having established rapport and built trust. And, we are a person in their life when we're counseling with them to help them determine what is truly a crisis and what feels like a crisis, but actually is probably going to resolve itself in a couple of days. Right. The sense of urgency, I wrote down urgent versus important. It's like it feels urgent. Also, there can be diminished ability. I like that. Diminished capacity for delayed gratification. It's like, no. I can't wait. This has to happen now. No. And our clients can box themselves into, because they've been often living a life where if they've been addicted to a substance and perhaps they're subject to severe withdrawal, they have been in a position where now is very
now,
right for them. Bad things are going to happen if they don't get exactly what they need, at this point. So trying to get them through that crisis phase where, problems sometimes seem bigger than maybe they really are. We want to reframe. And again, it's that basic counseling skills you're going to pick up in your foundations class and certainly in the advanced class. You don't turn to a client and go, listen, this is not a problem. What you need to focus on is your kid thing. It's like, you validate. It's like, oh my gosh, this is blowing you away. Let's disaggregate some of this, what is this piece and what is that? And you talk, and then they may come to the realizing, actually, this probably will work itself out in a couple of days if I just calm down. So we need to do that, but it's crisis intervention is certainly a big piece. Christy, an example of crisis intervention before we move on?
Absolutely. So, the MTA, if a person is an early morning, let's say a patient is an early morning person, and they get to their appointments for like a medicated assisted treatment program, and they now have a routine where they know the clinic opens at 6:30. They want to get their first medication at 6:30, but the train was very much delayed and they're not getting there until 7:15. Well, in their minds, they're already.
Yep. You're muted. Something happened with your mic to mute it, Christy, so I'm going to unmute it. There, unmute. There you go. Okay. Well, hang on a second. I'll take care of it from here. Okay, Christy, your mic was muted for a minute, and we're giving an example of someone on medication-assisted therapy. They need to get to, to
Yesterday.
to get their appointment, and something happens. So where does it go from there?
So all of a sudden, let's say they get to the clinic around, I don't know, 7:15 a.m. In their minds, not that they're physiologically feeling withdrawal, but in their minds, they're feeling like they're in withdrawal. So what happens is that the client will say, this is a crisis. I didn't get medicated on time. They'll have a high level of emotion. They'll feel like, nothing is working for them. Everything went wrong for them for the day. They'll have a high tone voice, high, pitch, high, and for them, it's a crisis. They can't think. They can't, and so what happens is that you take that moment and you say, this is a teaching and learning moment. Let's learn what's happening to you physiologically. Okay. Are you feeling withdrawal symptoms? No. Okay. Are you feeling any mental symptoms right now? Any issues with psychosis, right? Because we know with methadone, it's an antipsychotic property. It has antipsychotic properties. We're going to talk about that later, I'm sure. But the idea is you walk them through the process and you say, here it is. I see that you feel like you're going through a crisis right now. Do you still feel like you're going through a crisis? Because you have all these things in your mind. However, is this really happening to you? And the client will say no, and then they'll take it as, okay, I understand what happened to me. I've learned from this experience. I know what to do going forward. So it's every crisis becomes a teaching and learning moment.
And they're often fear-based events. They're afraid that they're going to lose something that they have, and that could be up to and including their children or their housing or whatever, or their job. Fear that this is going to happen, and they see it coming to be, or that they're not going to get something that they need or want, that they're not going to get the benefit, that they're not going to get admitted to the training program, that they're not going to, crisis can arise out of different elements of the treatment plan, and it's our job to help case manage them through the realities of it, and then to use our counseling skills to help get them through that. Thanks for that example, Christy. We'll move into client education. Sometimes the more they know, the less they're afraid, and sometimes you can diffuse a crisis just by providing it. It's like, oh, didn't you understand that if you miss that deadline, there's a 72-hour grace period? Crisis over.
That's right.
We just need to provide information to individuals and groups. For years, do they still call this psychoeducation? I haven't been in
It's psychoeducation. Go for it.
Doing psychoeducation. Psychological education is what it means. Not educating the psychos. Now, come on. It is psychological education, and it is telling people, oh, did you know that? I mean, often they don't really have a way of describing their addiction using words. They don't have a way of describing what's going on in the relationships around them using words or having conversations about that. We need to improve their vocabulary, give them information, give them the language of addiction that you guys are learning. We want our clients to be able to have that language as well. And to just be aware there are these systems. There are rehabilitation programs, there's education programs. Our case management is often, just the fact that we're doing these things with people is providing education to them. Do we want to speak more specifically about that, Christy?
Yeah, I always tell like any social worker or any kind of counselor that client education is very specific. It really is based on what the client needs or what you found in the client's treatment plan.
Sure.
For example, let's say the person just had a medical condition. that right that they never had before. You always want to take primary sources that discuss that particular type of medical disorder to the client. So one, it's never misleading, and two, it comes directly from a medical source because we're not medical experts. So
Sure.
client education is very specific, and it can be used in individuals, and it can also be used in a group setting, and it can also be used in a peer setting as well.
Sure. So client education in the medical example you were just giving, I think there was a little bit of an audio hiccup there. In the medical example you were giving, we want to be sure that the clients have proper information from an authentic source, from a real source, and we want to dispel misinformation or myths that they may
Absolutely.
have about what's going on with them, medically, or what the implications are of gone on with it. I've had many clients say to me, I've done this so long, my brain is never going to be right again. I'm like, where'd you hear that? Let's talk about whether your brain is ever right again after, or to what degree can the brain heal and recover from having been saturated in opioids for a couple of years, or to what degree can
Absolutely.
the memory issues associated with long-term alcoholism, to what degree does it come back? It we're just providing some basic education about the diagnosis and the implications for it. And that's a big piece of what we do. There's whole classes and modules that go on and that are taught in treatment settings. Let's talk about the referral process a little bit. Identifying the needs of a client that can't be met by the agency that you're in. Requires the helper to be proficient in identifying and connecting with various community resources. Sounds a lot like case management, Christy. How's it different?
Actually, it's a little different. This
Okay.
means that we're not hoarding clients, which is kind of typical in both nonprofit organizations and for-profit organizations. They try to tend to keep clients in their organization. But here's the deal. We're really supposed to be referring our clients out if it's not our level of expertise and it's not our scope of practice. For example, if we're just a substance use treatment program and all we do is provide substance use treatment, and the person needs something like psychiatric services, of course, we shouldn't hold the client with us only. We should be working with a psychiatric professional to provide psychiatric services to the clients. But if it's a one-stop shop, like there are many organizations that have many different programs inside of their organization, sometimes our clients will say to us, well, you know what? I just want to come to you for substance use treatment. I don't really want to come to you for primary care. I know it's right upstairs, right? I know it's on the third floor. However, I really want to keep my primary care services at, I don't know, another hospital. So the idea is, if the client doesn't want to, whether they're satisfied or unsatisfied with the services, but doesn't want to have services with you in particular, the idea is to refer them to a place where they may be comfortable so they have the best outcomes.
Mm-hmm, mm-hmm. And there's a variety of reasons that clients will need to be referred elsewhere. And your example of the co-occurring psychiatric is very on point. While we want to be treating co-occurring psychiatric, anxiety, depressive, mood, mental health, like schizophrenic or psychotic disorders, we want to be treating that in as integrated a fashion as possible with a continuum of care. We want the providers working together. There are times when, well, we don't have a psychiatrist here, so, we want to communicate with that psychiatrist, but they're going to be referred to that person. The other is, say there's psychosexual issues, or someone wants to deal with, sexual identity issues, etc., and it's not a specialty that you have, or it's not an area that's really covered as well. It's like, well, we're going to refer you specifically for this. So there can be a variety of reasons that you'll want to refer people out. What I found through years and years of practices in private practice, where I've spent most of my career, you'll find people in private practices, you mentioned hoarding clients. It's like they're going to keep anybody that they possibly can treat with any degree of efficacy. And I was in the position of receiving referrals from general psychotherapists who were out of their league with addiction. They're like, I cannot treat this. trying to deal with the personality. I'm trying to deal with, trauma is the other one I wanted to bring up, Christy.
Right.
Maybe you're not a trauma treatment person. You're implementing a treatment plan for the psychoactive substance use disorder, but there are other child abuse, trauma issues. The gender of the therapist comes into play. So there's a variety of reasons why we're going to want to refer somebody to another practitioner or to another specialist to work with what they have.
Or from substance use treatment provider to substance use treatment provider. Because here's the deal. When you're working in an organization or hospital, they may have a very specific model that might not work with the client. Mm-hmm. So, maybe the substance use treatment provider may just have DBT, and all of their practitioners will specialize in something like DBT. Well, the client, that model may not work for them, right? Mm-hmm. Mm-hmm.
So you'd refer them to a substance abuse person, or it's like, I'm going to be much more comfortable with someone who's real familiar with the 12-step stuff. I don't want to have to be talking about step 3 and you're not sure what you have to look it up. It's like, I'm going to be more comfortable in a 12-step facilitation kind of model than I am in a dialectical behavior therapy model. Okay, I know the heavy weight of 12-step counseling, and he's right over here, and we're going to refer you that way. So yes, make sure people are getting the right counseling that they need. Excellent.
Absolutely. Yeah. And just a short story, Dr. C. What happened was that I was working as a treatment provider, and I was very specific with CBT and motivational interviewing. And of course, we use models of stages of change. However, the client had been to multiple clinics, outpatient clinics similar to mine, that had the same type of model. What the client actually wanted was psycho-informational therapy, where the person consistently received information regarding what was happening to them, understanding their emotions. Nice. The client really wanted, right. So we had to transfer him from one outpatient to another outpatient, just because the person needed a different model.
Sure. And it takes a certain amount of critical understanding of yourself as a therapist and what model you're practicing with. It's like, this is what I use to implement, and it's not going to be the right thing for everybody. One size does not fit all. You can't run everybody through a 12-step program. You can't run everybody through dialectical behavior therapy. Cognitive behavioral therapy that includes a lot of writing down, homework, record of, thought tracking, et cetera, that doesn't work for a lot of, people. They're not going to be able to keep a thought journal or, that kind of thing. So we definitely referral. I love the way this conversation's gone, Christy. Referral is really part of the process of making sure that the client is getting the best service available for them that is going to work with them and get them to the outcome that they want in their treatment. Reports and record keeping. Oh, social workers just love writing reports and keeping records. It's the first thing they want to do, right?
Liability.
And you won't get paid if you don't. I'm sorry.
Right.
It's Christy, you've taken a course with me. Why does Conley want his assignments in on time? Because in the real world, you have to have your reports in.
You have to have it on time.
If you don't, you can't come in the next day. It's like you can't see any more clients till you finish writing your notes.
Nope. Right. Notes are usually done right after you're finished with the patient, and can, most of the time in nonprofit or for-profit organizations, they want it done in 24 hours, man.
And integrated electronic medical record system is the way we're headed. If your agency's not there, it's going to be there. Your private practice can be there, so that it's all part of the same thing. You have your documentation, and it's tied to your billing, and it's tied to your keeping track of patient outcomes, et cetera, et cetera. And increasingly, the payors, the people who are funding social work services, they want to see that, there was an evidence-based assessment, a treatment plan written, that the treatment plan has been updated, that it's been implemented, and that, you are documenting your progress towards your outcome, your treatment goals and outcomes, that you're documenting that on a session-by-session basis. So it has to be charted. And, I don't know. Do you have anything from the real world about we don't get paid because our charts are a mess, Christy? I know some agencies blow up over this.
It's a little bit more than that. Here's the deal. If this is a liability issue,
It
if you
is.
bill for a patient and you don't write the notes, and Medicaid comes in, they're going to roll the dice and they're going to say, well, this is how much we paid you. You have to pay this times the dice that we roll.
Yep.
So, and you can be held responsible individually, and your organization can be held responsible as well.
Yeah, it's an audit function, and I had rattled my brain about 7 years ago, an agency south of here in a very rural area, and it was a crucial agency to the area because it was the only one and only for like this huge geographical area, and it went down. I mean, it went down over a Medicaid audit that they couldn't because they had to pay back money that they thought, because they'd billed it for a couple of years. And it was such a big hit. I'm not sure if they pulled it out or I think another agency came in and satellited out there, but there's real implications for keeping your reports and record keeping writing. So yeah, there are deadlines and they are important. And if things don't get done, there's consequences. So.
However, there's also another tail to this story, Dr. C. So the other tail to this story is the type of writing that is in this type of record keeping. A lot of people say, well, I've got my notes in on time. I've done a great job. And I'm like, fooled you. No, you have to write this in clinical language. As a social worker working in the addictions field, you have to use the terms. You have to use the type of intervention. Again, your theory with your practice comes together in your notes because your funders, whoever that funder may be, is always looking for the golden thread. How well did you write? How many interventions? Did these interventions work? And if they didn't work, did you change the intervention and practice type?
Sure. So not just did you do it, but did you do it right? And
Exactly.
did you use proper clinical language? Did you use the necessary clinical language to do it? And that's an experiential based thing, which is why all the students who are going to move in a CASAC direction or move in the direction of working in primarily a substance using agency will learn the language. There is
absolutely
one of our assignments this module is language, learning how to do that. And Conley is a big fan of talk and type or speech recognition language. The way my wrists work in my demographic is I can get a lot more words per minute out if I can talk into the computer and have it type up what I'm saying. And it does. I'll give an example of that to the class later and just try to be a proponent for being able to speak in whole sentences, to speak in whole paragraphs, kind of like what Christy and I are doing now. But to do that with the proper kind of clinical language, it can be a real lifesaver in terms of keeping up with your reports and record keeping if you can dictate your notes and have them show up on the screen in the right way. Consultation, and then we'll start wrapping up the lecture. We're going into about an hour here, so we should start bringing it home. Consultation, what can we say about here, Christy?
So consultation is really looking for a level of expertise outside of your own base of knowledge.
Oh, yeah.
We don't know everything, so it's always great to ask questions from the experts.
Mm-hmm. Mm-hmm.
So we spend a lot of time looking for resources. We look, especially if the client isn't comfortable talking to another type of resource, we ask them for primary documents, what the process may be like, and then we basically interpret that or summarize that back to the client.
Sure. And we may, if the client is legally involved, we're going to want a consultation with the lawyer or probation officer because we don't know that system. I mean, we're not, it's like, oh, no. If we revoke the violation, then, that doesn't mean that they're out of, they think they're as soon as they hear, oh, violations revoked, they think they're home gold. It's like, no, because Nassau County's still looking at it. It's like, oh, new charges.
Still got a warrant.
Okay, so helping clients disentangle different, and we need that. We need to know what does this mean for the court system? What is or the medical stuff? I mean, we're clearly out of our league with some medical stuff. It's like, I don't know, there's if hyperthyroidism gets treated, does the manic symptoms go away, and how's that going to affect their alcohol? So we need to talk to people at some point, doctors, lawyers, et cetera, makes sense. Even benefits consultants, it's like negotiating. And I know in private practice, negotiating some people's, private insurance plans is crazy. I needed a benefits specialist to say, well, if they do this many days, but it's an out-of-state facility, but what if it's an ins network and so you have to get the consultation, and just knowing what you don't know and who you can talk to get that information makes sense. Cool. We have covered, hate to have a blank slide come up. So we have covered these 12 core functions that of working in addictions counseling. There's a lot of other reading and stuff that goes along with this module, but hopefully this has been helpful from a live lecture perspective in a semi-formal discussion format to provide a lot of information on these that will hopefully stick with the clients. Chris, do you have any other ideas before we start finishing up, or before I start trying to close this down?
No.
Sounds good. Great. We'll be putting together more lecture material here shortly. Thanks there. And I'm